So the OPTIMISMM trial compared pomalidomide with Velcade and dexamethasone against a standard arm of Velcade and dexamethasone, and data has previously been published showing an improvement in responses, but also progression-free survival in the whole patient population. In the BSH abstract, there was specific analysis looking at second-line treatment, in other words, people who've only had one prior line of treatment, and also looking at the responses achieved and duration of responses achieved in people who've had or not had prior bortezomib. Conventionally, certainly in the UK, bortezomib is given, as a first-line treatment in fixed duration. In other words, given for varying between 6 and 9 cycles, depending on the exact schedule, and then a period of time of observation, and then at progression, someone would then potentially be retreated either with bortezomib or indeed have a different treatment schedule. So the aim of this particular analysis was to look at the impact of prior treatments on outcomes associated with adding in pomalidomide to Velcade and dexamethasone. So the subgroup looked at 226 patients who were treated in second line, of which just over half had received prior bortezomib. And what the headline data demonstrated was that the progression-free survival of the 3-drug combination of pomalidomide with Velcade and dexamethasone was superior to Velcade and dexamethasone, irrespective of whether people had had prior bortezomib. So the PFS was nearly 18 months versus 12 months of the triplets compared to the doublet in those who'd had prior bortezomib. Perhaps not surprisingly, the PFS is slightly better in those who have not had bortezomib at all, given that it is, of course, in both arms a bortezomib backbone, but that was 20 months versus 9.5 months in that patient group. And also, importantly, the triplet was also associated with deeper response rates. Importantly, of course, though, in any analysis, particularly a triplet versus doublet is looking at toxicity, and perhaps as might be expected, there was a slightly higher risk of neutropenia and also infections in the triplet arm. And that's certainly something that we perhaps would be expecting to see with pomalidomide, which is myelosuppressive, compared with Velcade and dexamethasone, which is more immunosuppressive than, strictly speaking, myelosuppressive. So certainly the improvement in PFS does, of course, take account of the potential for excess mortality associated with any treatment arm, and certainly the data still strongly supports using that triplet, but it's important that clinicians are aware of the increased risk of neutropenia and the increased risk of infection, and that's obviously particularly pertinent, the current era when we're dealing with COVID, to make sure that we are being extra vigilant in that regard.